team members. He's been in our department since 2002, worked in a variety of different settings, including with me on our inpatient unit, as well as on our consult liaison service and partial hospitalization program at times. Whenever he used to come and work on the inpatient unit, he'd always bring in a lot of information regarding forensics, malpractice, the legal aspects of what we were doing, all in the context of his primary work, which is as a forensic psychiatrist here within the department. And the co-head, or what's your official title within the
assistant director?
Assistant director of the forensic fellowship program. So when we were thinking of people to invite to come in, to come in and speak during this series, John was one of the first people who came to mind. So thank you very much for all of your work for the department and specifically for this today.
What we're going to talk about today is a little bit about malpractice and kind of explain what malpractice is, just so that you can think about it, have a better understanding of what it means, what attorneys are looking for, what forensic experts like myself are looking for, and ways to minimize your risk. It's really okay if we can just pull up, just the presentation. I'll just do that.
Okay.
Thank you. So, I want to make sure that people feel free to grab a copy of the handout that has the slides. If we run out, I am happy to send folks my slides, because there's nothing really earth-shatteringly secret in there. Just a show of hands, anyone here been named in a lawsuit ever, or know someone who's named in a lawsuit? Okay. Who here thinks the sound of being named in, called as a witness in, or otherwise like walking by a lawsuit happening sounds like a good thing? Yeah, it's not pleasant. It's not pleasant when I'm the forensic evaluator and I'm not the one like being examined directly. It's not fun being a fact witness, which is how I've been involved in them, just sort of saying like, well, this is what my attending did and this is what someone else did and this is how everyone else screwed up, sort of thing. You know, it's just not fun. And basically, a malpractice case is a civil case. It's not a criminal case. It's what's called a tort action, which is a civil wrong. And basically, the defendant in a tort, a civil case, has allegedly done something that's led to harm or loss on the part of the plaintiff. And in general, what they're trying to do is they're suing for monetary compensation for that loss or harm to make the person whole again. Few things that come up, again, because it's not criminal and you're only talking about money, which is a lot easier to do if you're the judge sort of making law as opposed to the person being sued. But if you're only talking about money, the standard of proof, the level of proof they need to show that the defendant did something wrong is lower than in a criminal case. So criminal case, it's like over 90% sure. You know, it's beyond a reasonable doubt. There can be some doubt, but there's no reasonable doubt left that the person is guilty. In this kind of civil case, it's preponderance of the evidence, more likely than not, 51% likely. There's an intermediate level of proof that comes up with things like conservatorships and certain other proceedings, which is clear and convincing that you might see, and that's like 75% certain. But here we're working about preponderance of the evidence. The other concept is burden of proof. The burden of proof speaks to who has the responsibility for showing what happened. So if I am going to sue Dom Tarpey for something. I'm the plaintiff, he's the defendant. I have the burden of proof. I have to show that he did something wrong that caused me harm or caused me loss. And the standard, the level of proof I have to show is it's more likely than not that he did this. When we talk about the tort, or in this case a malpractice claim is the tort, it is important to realize there has to be a duty of care. So like if I'm just walking by someone and they trip on a stairwell that's maintained by Dr. Sikorsky's company, I have no duty of care because I'm not an employee, I'm not the caretaker of that person, I'm not the caretaker of the property, I'm just like random guy walking by. So I can't be sued by Dr. Saunders for walking by as he tripped on something that's owned by and maintained by someone else. There's no duty. So there always has to be a duty of care. Now, lawsuits can happen for different things. You can have injunctive relief, which is the big exception. And this is where you'll see like people are suing different parts of the government. So like I'm suing the EPA to block them from instituting a policy, or I'm suing on behalf of prisoners who have been subjected to substandard care. What I'm saying is I'm not suing for money, I'm suing to prevent harm from happening to someone else. And if this policy were to go forward, it's likely that irreversible harm would happen. Like if this policy goes forward, like my constituency that I'm suing on behalf of will be irreversibly harmed. So like, they'll kill off, I don't know, all the armadillos, and that's where we got the idea of how to cure leprosy. So we should like not kill all the armadillos because God knows what else they'll cure for us. You can sue for compensatory damages, which are the make you whole again sort of things. Like, what were the costs of your medical care? What's the likely cost of your medical care? What are the, what's the property that you lost? What are the wages that you lost? Things like that. Thank you. So it's the actual cost of your loss or harm. And sometimes you estimate it. So I might be asked, okay, Dr. Guo was in a car accident. She needs this kind of medical care. She needs this kind of psychiatric care. What's it likely to cost? How much care will she likely need, and how much will that cost? Because then the defendant's going to be on the hook for that. And there would probably be like an orthopedic surgeon, and maybe there's a neurologist and a neurosurgeon and various other experts who would sort of say like, this is the cost of the care that she's likely to need. And obviously, if you're an attorney, you want lots and lots of costs, because then you get lots and lots of settlement and you get a percentage of the settlement. Punitive damages, on the other hand, are, as the name would imply, extra. They are to punish the person who did wrong. So this is the plaintiff, the court being able to tell the defendant, don't ever do that again. So a lot of times when you see corporations, thank you. A lot of times when you see corporations being sued, what they'll do is they'll say like, okay, you released X chemical into the water supply, people got cancer, here's how many sued in time, and now here's their actual damages, here's what you're on the hook for. But this was so egregious that you spilled this chemical and then you tried to cover it up, or this was just such a big breach and we don't want this kind of behavior repeated, so we want all the other companies to get the message. We're going to also tack on what was the big case just recently with like Monsanto and Roundup or whatever, and it's like, here's like $700 million. It's like, that's not because the guy in front of them was going to ever make $700 million in the rest of his lifespan had he lived to like kind of the average human lifespan or even within his family. That's like, a lot of that is punishing Monsanto, and it's got to be enough to like get their attention. So it's not like, oh, and we'll fine you $1,000, because they're like, okay, like I probably lose that much when I change my socks if I'm like the head of Monsanto, Okay, we solved one problem. Okay, now it's working, okay. So the standard of care is very important for, I was afraid to do that because I was like, it's finally working. I just was like, okay, I don't want to rock the boat too much all at once. So the standard of care has both kind of a clinical and a legal implication. And on the clinical side, it's the protocol or process that a treating provider should stick to with a particular type of illness, a particular type of patient or clinical circumstance. So the standard of care, if someone comes in and says they're depressed, is going to be, what are some things you're going to want to know? Residents, don't make me start calling for volunteers. What's something you should test, Dr. Zhang, or ask about?
They're coming in with depression, like Ziggy tab depression.
Yeah.
Scale, past history, past medications, and suicide attempts, suicidality, risk assessment.
There's a biggie that you forgot. If they have any evidence of...
Manic symptoms.
Exactly. So it would be sort of a breach of the standard of care to not ask about a history of bipolar symptoms in someone who comes in with depression. This is just what you do for that kind of disorder. That's what you do for that kind of illness. If you're going to be treating someone with Clozaril, what's the standard of care? Like something that jumps out.
Blood draws.
Exactly. For what?
White blood cell count.
Exactly.
Differential.
Yeah. I mean, it sounds kind of obvious to us, but like the reason I kind of go over this is it's not a big like foreign concept. It's what you do, but we kind of get sort of a mythology in our heads about how big a deal this is. The legal concept adds a little bit more to it. It's basically the level of care which a prudent or reasonable clinician would exercise in the particular community, or how would similarly qualified practitioners have administered treatment in identical or similar circumstances. And you have to, if you're being sued, if I'm going to sue you successfully, I have to show what the standard of care is in the community in which you're practicing, and I have to show that you violated it, that you fell below the standard of care. Couple of things to remember. The standard of care is not the standard of excellence. Okay, this isn't like we did cutting edge fMRI, like all these inflammatory biomarkers, and we did genetic testing, and based on all that, here's our algorithm of like what you should get. It's what the average, a reasonable person practicing in the community is going to do. And so at UCSF, we tend to have, as most academic centers do, we tend to practice somewhat above the standard of care because we ourselves pursue excellence. And that is in fact a good way to protect yourself against malpractice, is, you know, kind of get a sense of what the community is doing. So like when you read notes from outside and they're like no SI, no HI, continued treatment plan, you kind of see like a few hundred of those from different practitioners and you're like, okay, that's the standard of care in the community. I am way above the standard of care. But it's important to realize that, because if you're ever consulted on this, it's not what would Dr. Chamberlain do. So like if I'm asked to go in on a case, I've had plenty where I've said like, if this was my resident or this was my fellow and they practice this way, I would slap them upside the head. I would fire them, I would kick them out of fellowship. I have failed trainees before I see people laughing in the back. I have failed trainees, not often, but I have. Dr. Sikorsky has been in on meetings with me where I have let loose my feelings about people. And he's smiling because he knows I'm speaking truth. But basically, I've not failed anyone you guys would know, in case the gossip's going on back there. But it's, you know, at the same time, when I look at those cases, I have to then say like, but that's not the standard. The standard is not like what I would do. It's what's average in the community. And attorneys always want to know what the standard is. And it's hard to tell because they'll say like, oh, well, the APA has practice guidelines. There's the Texas medication algorithms. These all must be standards of care. But if you look at those things, one of the very first pages in all of them says, this is not the standard of care. This is like an approach. This is like kind of a summary of like knowledge of prudent practices, but it's not meant to define a standard of care. So how do we establish it? Dr. Saunders, you're a bright person, but let's say somebody comes into the AIP and stumps you with what to do. What would you do?
I would go on PubMed and start looking at what the literature.
Okay. Anything else you do?
Discuss with colleagues.
Yeah. So that is also a great pearl in how to protect yourself against malpractice claims. Is if you consult, like if a resident consults with you, let's say it goes like PGY2 consults with PGY3, Dr. Zhang, who consults with PGY4, Dr. Guo, who consults with you, who consults with PubMed and with, say, Dr. Booty. Like, you've by definition kind of like established a standard of care. Like, here's what we all got together. We had multiple clinicians come together. Residents on call a faculty backup. Well, of course I called my faculty backup and discussed the case. Well, then it's like we're just sort of getting into like, okay, we're defining a standard of care because you have multiple people consulting on this who are, you're sort of getting a sense of what the average is. And again, probably in an academic center, you're going to exceed the community standard of care because they might not even check the literature directly or stuff. But like that's where things like UpToDate, checking PubMed, all these things are ways to do that. So it's also important to know like whose standard of care we're talking about. So it's not uncommon that like I'll be asked to consult on a case, but the issue will come up around like nursing or psychology. And sometimes there's stuff that's just so obvious, everybody can get it. You know, like I had one where at an academic institution, they recognized the person was in delirium. They did not do a great job of treating the delirium, but it was passable. And they put a sitter with the person. And the sitter did the most beautiful documentation jobs ever. And it was like, patient agitated in bed, patient gets up from bed, patient walks around room, patient walks out of room, patient walks down the hallway, patient turns corner, no longer can see patient, patient does not return. And we went and looked for patient, could not find patient. Later they find patient having fallen many stories and patient being dead. But it was an amazing job of documentation. But it was sort of like, okay, well, why weren't you telling anyone that the patient's leaving? Why weren't you getting like higher levels of care? This like doesn't take like really an expert to tell you you probably shouldn't have just like watched them wander away. But you do want to know, like, if it's about, like, how do you fill out an MAR, if it's about, like, how you check dosage coming from the pharmacy versus a physician's order, that's probably something where I would say you need a nursing expert to tell you how to do that, not me as a doctor, because that's not something that I'm doing on a regular basis. Could I do it? Yeah, I can figure it out, but I'm not, like, going to be able to say I'm an expert in reviewing that. So, there are the 4 Ds of malpractice or a tortuous act. Attorneys have, like, the best language. They have all these cool terms of art and these Latin terms. Don't let it scare you. There are 4 things that are the 4 Ds. Number 1, you have to have a duty. If the person is not my patient, I don't have a duty to provide any care for them. So I can't be sued if something happens to them. I'm like walking through the ER to do a consult on person A, but as I walk by, person B drops dead. That's not something that I could be sued over because I wasn't involved in the care. There has to be a dereliction of the duty. So not only do you have to have a duty to the person, so like a doctor-patient relationship, but you have to breach that. You have to be derelict in your duty, or this is where the standard of care comes in. You have to fall below the standard of care. And that has to directly lead to damages. So, if, let's see, if one of my surgical colleagues from back in the day, when I was a surgeon, walks into the OR to do a transplant procedure and is visibly and olfactorily drunk and under the influence and doesn't get to operate on the patient, has there been malpractice? Got a duty. You probably shouldn't show up drunk to do a procedure, right? OUI is reason to be booted out of a residency. Anybody want to go out on a limb?
It's not malpractice.
Yeah,
Why
technically not.
If you didn't do the surgery.
Okay. Perfect, yeah. So there's no damages that could be attributed to the care. And it certainly isn't directly related to anything that guy did. Let's say he does do the surgery. And he gets a new, let's say, kidney, and it pinks up and it starts peeing, which is like the coolest thing in the world. Everyone should see a kidney transplant. It like brings hope to your like jaundiced view of life. And you never get so excited over pee in your life. It's quite amazing. And everyone's like looking. So it's like peeing all over the abdomen. But that sort of side note aside, let's say all that happens, the person's discharged with a normal post-operative course. Has the person committed malpractice who operated drunk?
No,
Why not?
there wasn't harm.
Yeah, there was no harm, there's no damages. Now, is it improper? Could there be other issues that go on? Absolutely, but it's not a malpractice case. Now, obviously, if the person does everything like they're supposed to and they're sober, and let's say they nick one of the arteries and they bag the kidney by mistake and it dies, even though they were sober, they're the one who kicked drunk dude out, you might have a malpractice case because like, well, were you careful enough? Well, it's known to happen, it's a known complication, but you'd have experts kind of going in and saying like, what was your technical procedure and did you do it well enough to meet the standard of care or not? Okay. So if you undertake care for a patient, I'm trying to make up a little time for us, then you have a doctor-patient relationship. And this gets a little fuzzy because there have been cases where somebody calls the clinic and somebody says like, yes, we will put you in touch with one of our outpatient intake coordinators and something goes wrong and the person kills themselves or tries to before they're seen, and people will have been sued in cases like that, like because they called and someone answered. That meant that they're now a patient and there's a duty to provide care. It gets a little fuzzy, it's hard to do this, and this is one of those things where, again, experts would come in and say, like, you're talking to non-clinical staff, this isn't like a doctor-patient thing, this is essentially like you left a voicemail. It's, you know, or no, actually, the way they did it, this is actually establishing a doctor-patient relationship. Social settings don't count. You meet someone on whatever dating app young people are using now, and you say like, hey, I'm a doctor. It's really cool. That does not, and they say like, oh, I have this mole. That is not going to get you in trouble. Now, if you say like, well, you know what would be great for our second date, I'll biopsy the mole, then you might have a problem. So don't do that. That's like a fifth date thing.
Yes. The one that my friends and I always talk about is helping in an airplane when you're calling this position in the middle of the Pacific, or I suppose a car accident.
See, I didn't even have to pay him for that. We're just simpatico. No, that is a great one. And it's an interesting question. JAMA just had a whole article about like what to do in airplane emergencies. And a lot of times it's basically like you're a highly educated witness. Because like, you know, I trained for years as a surgeon, I worked as a hospitalist and intensivist for years. I can do a lot of things. But like if I'm on an airplane in the middle of the Pacific and I look at their, you know, medical kit, I'm probably like a highly trained and educated person cursing, going like, well, can't really do crap. Okay, well, you can give like education, like watch the tension pneumo, like slowly kill this person, you know. Like, but you can't do much, but they want you to, right? Society wants us to. They want us, when we can, to use our training to help. So basically, the law limits, in some cases, your liability, even though there's a duty. So these are the so-called Good Samaritan laws. Because as I'm like driving down the highway, option one, I can do what a lot of clinicians do, and I know clinicians who do this, and they're like, this is off to the right-hand side. And they're like, hey, look, I think it's Elvis. Doesn't that cactus look like Elvis? And people are like, what are you talking about? There's a huge wreck over there. And I'm like, yeah, but look at the cactus. Oh, there was a wreck? Oh, that's too bad. I wish I'd seen that. 10 miles away. Like, nah, can't turn around now. But California has, as is often the case, done some weird crap. So basically what happened is one of the courts of appeal and then the state Supreme Court upheld like a case that they said like you shouldn't have moved this guy. It wasn't medically necessary to move him, and all the Good Samaritan laws cover you for good, you know, like good faith things that are medical care, and moving this guy wasn't. It wasn't medically necessary, and this guy suffered injury for that, so feel free to sue. And you can imagine a lot of people were sort of upset with this because they were like, well, now you're going to have a lot of people going like, well, I don't know if it's medically necessary to move him, and the courts say, well, it might be, but it wasn't in this case. So a lot of people are going to say like, hey, look, the cactus looks like Elvis. You know, let's have a detailed discussion about that. People don't want that. People want people who are trained by the Red Cross in medical school, in nursing school, you know, the military, if you're a corpsman or whatever, they want you to actually help. And so what the legislature did is basically make this amendment. So no person who in good faith and not for compensation, so if you take any money for it, don't. If they want to give you a gift, don't accept it. Because anything you do, because that takes you away, anything of value that's given to you, and if they want to like hug you, shake your hand, take a selfie with you, that's fine. But if it's for monetary gain or has any inherent value, then that's compensation, and you're not acting as a volunteer or a good Samaritan anymore. Renders emergency medical or non-medical care or assistance at the scene of an emergency shall be liable for civil damages resulting from any act or omission other than an act or omission constituting gross negligent or willful or wanton misconduct. So basically, they tried to close the loophole. Now, they didn't, because like gross negligence, it's a little hard to tell. Like, I do a lot of like community emergency response stuff, and this is what we actually discourage. Like, you know, it should be trained people like trying to turn over the car or getting people out. You know, like, because you can do a lot of damage. And like people who rush in, like kind of untrained people who are rushing in like after a disaster like an earthquake. They had like a thing in Mexico City when there was a big earthquake, like they saved 75 or 80 people, but like 300 of the would-be rescuers got injured or killed. So like on the whole, it was actually worse to do it. So you don't want to necessarily just rush in, but you have to use some level of prudence. And we're pretty good, you know, if you've had medical or first aid training, to know like what your limits are and what not to do. Now, the dereliction of duty is what the standard of care is, and that you failed it. You need an expert for this, because the jury's not going to know what the standard of care is. They're not going to understand the differences. You can certainly have people who come in with just like fanciful levels of care. Dr. Sikorsky, we see this every year at the civil mock trial, right? Where the argument is basically all that, like, you should have moved in with this guy that you discharged to prevent him from suiciding, like weeks later. You know, and it's just unrealistic standards that are thrown out there. And an expert has to sort of come in and say, like, yeah, you could do all that, but here's what the standard actually is. And did the person meet it or not? Now, there might be cases where it's so obvious that you don't need expert witness. And this is res ipsa loquitur. The thing speaks for itself, or the thing itself speaks. So you can see here, you know, the guy waking up dead in the morgue, or from being dead in the morgue, that's pretty bad malpractice, right? Like, anybody ever watch Frasier? You're like, one where he's like, are you sure he's dead? And he's like, you don't make that mistake twice. And then this guy, if you can see, like his left foot is facing backwards. So like he had his orthopedic surgery, and so that's his. Like, you don't need an expert to tell the jury that that isn't how it was supposed to go. And this guy, of course, it's pretty obvious that had something going on, and he did have damages directly from the malpractice. So his head got sewn on backwards, and now he doesn't know if he's coming or going. So he's had his loss, he suffered his harm, and it's pretty clear. You can see the doctor looks not all that terribly plussed by this, so you gotta wonder how many malpractice claims he has. And there has to be damages. So here you go, the surgeon, on reflection, I admit the hernia stitches were too tight. So with the guy like whacking himself in the head. And so he put in the stitches. That was the right thing to do, but he put them too tight, and now there's damages from the stitches being too tight. This would be malpractice, right? Let's see here. Covered punitive. Okay. So I added these 5 and 6 for how to defend yourself in these cases. D5 is documentation. And again, like that story I gave is not to just say like, here's exactly what was happening. Like I watched the guy slit his wrist and boy, it was bloody. And you know, you're not just like recording it, you're recording your thinking. This is what my assessment was. Mr. Jones has major depressive disorder, recurrent, moderate severity. He has SI without a plan or intent. He doesn't have weapons access. He's future oriented. He has all these supports in the community. He's had similar symptoms in the past without attempting suicide and has responded to treatment. I reinstituted the treatment he's responded to before. I gave him my number, crisis numbers, blah, 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 blah. He declined voluntary hospitalization, PHP. He's willing to see me in a week. So I went along with that and he's not holdable. Okay? You know, that's something that if you're in court and they put it up on a big screen like this, like attorneys love to, the jury is going to be able to look at that and say, what did you want the clinician to do? He checked. Your client wasn't holdable. He gave him voluntary options for higher levels of care, which your client declined. He also found that the person has been in similar situations before without having attempted suicide. This is the treatment he was willing to do. It's worked before. They instituted. She gave him all kinds of crisis numbers to have just in case, and your client didn't call, he attempted suicide. What else did you want the clinician to do? You know, as opposed to like clinician said, see me in 6 months, you know, something like that. And that's what you want. You want it to lay out what your assessment was, what your plan was, and why. So that's why like on our progress forms here, it's like, you know, acute risk of danger to self, danger to others. Like what are the risk and protective factors? What's your overall global assessment of their risk? What are you putting into place to like minimize that risk? Now you're not required to be right because you can't predict future behavior, but you're required to do the right kind of assessment. Now, in addition to this, a couple problems that can come up in your chart. Now, the great defense that a lot of people sort of fantasized about before we had electronic health records was the little kid on this side. I do have a note from my doctor, but nobody can read it. Okay, I'll just write it so messy that I'll just say like whatever I need to say to cover myself. You know, that tends not to work because like one, it's other doctors looking at it and people would say, even if I can't look at it, the fact that I can't read it is a violation of the standard of care because you're keeping documentation to not only remind yourself of what the plan was and what was going on, but like for covering clinicians and other clinicians to be able to step in if you're not available. So illegibility, not helpful. The one on the right is another thing that you don't want this to be on your note. So like chronic wimpitis, 100 milligrams grow the hell up pills, twice a day with water, supplement with over-the-counter chill pills as needed. Doctor, yo mama. Now, you don't want to be snarky. You know, you just want to be very neutral. I always tell people you don't want a lot of editorializing. It's like the patient comes in and says like, you effing piece of crap, blah, 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 blah. You know, I'm like, you know, the patient, he directed expletives at me, was clearly quite angry. I tried to like verbally diffuse the situation. I engaged in verbal limit setting. Eventually we had to terminate the appointment because of the abusive nature of the language. I invited the patient to schedule a follow-up or to come back at our normal follow-up time or to call PRN. You know, you don't want to be like, and this like no good SOB, again, sort of the way surgeons document notes, like, and this blah, 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 did this, and he's such an a-hole, and all this, because that's what's going to be up there. And then the jury's going to look at you, instead of saying, what else did you want the doctor to do? They're going to say, you're a mental health care provider. Did you expect that everyone's going to come into you and see you at their best? No, they're going to be angry, they're going to be upset. You're the one that needs to grow up, you're the professional, they're in crisis. and it looks like you have an accident, it looks like you're burnt out. And sometimes this can be where you penned a note, for example, in the electronic health record, and you say like, I'm having a really hard time. This person really made me so angry. I want to make sure that my documentation is clear and like just kind of the neutral, objective stuff that I'm supposed to do. So you might have like your senior resident or an attending just sort of read it and just sort of say like, okay, yeah, that looks okay. Yeah, sounds like the person was a jerk, but yeah, you weren't reactive to it. Because that's what you don't want. Because if you have good documentation, it can provide the sixth D, your defense. Because then your reasoning was clear. These things come up, they take years to go through. They can wait a year before they sue you, sometimes longer. And if you're sued and you're in a deposition and they say like, well, do you have any independent recollection other than what's in your notes of this person, you know, you can always say like, sure, I do. But you know, they're gonna say like, okay, well, what was the person wearing? Yeah, they're gonna go through all kinds of minutia and say like, so what else do you remember other than what's in your note? And you already look like you're not being honest, you're not being truthful, so you're not reliable as a witness. So you wanna have it clear. This is what I was doing. Like, and then if they say like, well, do you remember anything else? No, but that's why I document very carefully. What are the relevant factors at the time? You can sometimes say like, well, I always do this, if it's true. If you say like, you know, I always ask about the risk assessment. So all the residents here who've worked with me in clinic, how many times have I come in and asked you if you did a risk assessment? Anyone ever had that experience? Oh, you guys are lying. You're not raising your hands. Dr. Rampersad, did I ever ask you about that? Like, yeah, okay. We're lying. You'd be bad. Okay. So try to do like just one or two case examples. This one is an actual case. You can see this is stills from surveillance footage, and the person to watch is this one who's also circled. So a little after 5:30, a 49-year-old woman wearing a hospital gown topples over and collapses onto her face in a New York City psychiatric emergency room. After an hour, during which security guards and other people enter and exit the room, she's still laying there. Events are being recorded on video. She was awaiting inpatient involuntary psychiatric admission for psychosis and agitation. It was subsequently alleged that mistreatment of patients, including this person, violated the Americans with Disabilities Act and multiple New York statutes guaranteeing mental health services be delivered in a sanitary and safe way. The New York Daily News, not foremost amongst medical journals, but apparently not refuted in this case. Staff members had put false information into the medical chart after she collapsed. One example being that at 6 a.m. she was ambulating awake and had gone to the lavatory. At 6:20 she was sitting up quietly. And not only did the surveillance video contradict those reports, but when they did like her autopsy, she ended up dying. After they did the autopsy, they were like, for at least at 6:21, she was probably actually already dead. So that did not look good for them. But, so is this malpractice? Who says yes? Okay. Who says no? She got what she deserved. Oh, I thought you were raising your hand, Dr. Zhang.
No.
Bold choice. Okay. Yeah, I mean, this one's pretty clear. Like, this one is one where do you really need an expert to come in and sort of say that? Probably not. So, another one. Patient has depression, chronic intermittent SI, admitted to an inpatient psych unit, got antidepressant medication, individual supportive therapy, group therapy, being assessed for discharge, still had some residual depressive symptoms, no SI. They made a follow-up appointment about 2 months after the date of discharge. Day after discharge, person committed suicide. And the expert for the plaintiff says this is not the standard of care because you made the person wait so long. Who wants to say malpractice? Wow, tough crowd. Who wants to say not malpractice? Wow.
Depends on if you can prove that the appointment 2 months out contributed to the death
Yeah.
in some way, or not. If that person felt so despondent and they didn't have anyone to turn to and they thought, I can't wait 2 months, which you can't prove, really, since they're dead.
Yeah, so in this case, you could certainly say there's a duty. You could argue it would be pretty easy to find a lot of people who say, like, given the high risk of danger to self, danger to others, after an inpatient admission, that 2 months is too long. But even if you do all those things, Dr. Booty's exactly correct. Like, okay, there's damages, the person died, but the key is going to be, did that directly lead to damages? What if you had made an appointment in a week, in 3 days, in 5 days? Like, it would be very hard to say that, like, if you had done that, like, really the person would have survived? How would they have survived? It was 24 hours later. And is the standard of care to make an appointment within 24 hours? Now, if you could say, like, the person didn't get any other crisis stuff or anything like that, you might be able to cobble something together, but even then it would be hard to make that kind of connection. Yes?
So, if a patient walks out your inpatient unit and kills themselves, I think most clinicians would be found liable. And what I learned in residency and afterwards was it's about 24 hours after you've last seen the patient. So there's this 24-hour window where if there's a harm within that period, you as the clinician could be in trouble. So given that the patient killed himself the next day, like maybe within 24 hours.
It's tough though, because it would depend on who they sue. So in this one, they sued the outpatient doctor. And then, so like, yeah, it's not really for him or her, but like exactly, you could say, now did the inpatient doctors do an adequate risk assessment and provide an adequate disposition plan? And that becomes the difference. And some people, they'll argue beyond that, because they might say like, well, Dr. Booty's gonna see him in a week. Dr. Saunders was like the inpatient doc, but until he connects with Dr. Booty, it's sort of floating in the wind like it's yours. And so some people would sort of say like, well, when does that end? And that's where you have like experts come in and you want to know like, what does the documentation say? Because if it says something like, attorneys are masterful at picking apart language. So if you say something like, care will be assumed by Dr. Booty on February 7th, 2019 at 10 a.m. with his appointment, or you say like it'll be assumed by Dr. Booty and here's your appointment with him, attorneys will say like, well, so he wasn't involved in the care yet, which often works to their advantage because like who has the deeper pockets? Like you're the inpatient doc, you're employed by like a big institution, like that's who to go after. And so, there's all these kind of crazy things that I tend to tell people, there's not really good rules of thumb. A lot of times they'll make decisions that don't make sense. Like, for example, can you be sued for malpractice? Is it malpractice to have sex with your patient?
Yes.
Is it?
For psychiatrists, yeah, because we have an absolute rule against it.
Well, you have a
So it's
duty to your
unethical.
patient,
Yeah.
and you could,
Depends on what harm was done.
depends on what harm was done. As Anna Spielvogel, a analyst formerly of our department, said, like, you should never sleep with your patients because you're just going to disappoint them one way or another, either in real life or in the transfers. But in all seriousness, like, it actually isn't malpractice because it's against the law. So you can't technically be sued for malpractice for having sex with the patient. Now, what they will do though is they'll sue you not for the sex, but for manipulating the transference. So they'll still, because like if it's illegal and they sue you, they're suing you personally, you probably have less deep pockets than your insurance carrier. So they want to actually not sue you for that. They want to sue you for something that would be covered. So it actually becomes these sort of weird meandering things. So it's kind of do the right thing, you know, provide good care, be responsive to your patients, document your thinking, and that's your best defense, because people can sue you for anything. But again, you want it to be where they look at the chart note and go like, what did you want the clinician to do? He did everything he could. Your client wouldn't help. And you know, the clinician can't work harder at your client's recovery than your client does. But you also don't want it to be like the 100 milligram Wimpitis pills, right? Any other quick questions? I'm around if people have questions, but otherwise, thank you.